So I have been given this topic to talk on, and in the next 20 minutes or so, I'm going to endeavor to answer these few questions for you. Firstly, how good is CT in detecting bowel ischemia? Secondly, what can one do to improve diagnostic accuracy? Thirdly, what are the CT features of bowel ischemia? I'm also going to show you some cases to demonstrate these. And also, how consistent are radiologists at detecting bowel ischemia? Can we all agree that there is bowel ischemia? So I'm sure someone's get a second opinion from someone else. Are we in agreement, basically? So how good is CT? We're in an era in abdominal imaging where we can generate beautiful pictures, of the arterial tree to facilitate preoperative planning. We're also able to detect the smallest of cancers that's there on the CT colon to the millimeter. But for the longest time, the diagnosis of bowel ischemia remained pretty elusive to us. It was the unattainable holy grail of abdominal imaging. And when I was training in radiology, my trainers taught me, CT is not great for bowel ischemia. We have to rely on clinical features. And why is that? It's because when CT first came into mainstream clinical use in the 1980s, the very first study, so in 1988, Alpern et al. Retrospectively reviewed a cohort of 23 patients with surgically proven ischemia. This was retrospective, and they went back and they found the reports only identified ischemia preoperatively in 6 of these patients, so only 26% of them. And 2 years later, Sept et al. Identified also 23 patients, but they detected bowel ischemia in 9 or 39%, so not very encouraging. And CTs got better with multi-detector CTs coming into mainstream clinical use. By the mid-1990s, things were looking a little bit better. So in this group here, Abdo et al., he's published quite a bit on bowel ischemia, mostly in association with small bowel obstruction. But by the mid-1960s, the sensitivity achieved 64%, with reasonable specificity of 92%, resulting in overall diagnostic accuracy 75%. Still not good enough, so much so that at that time, the American Association of Gastroenterologists, they actually said CT is not great. We would recommend, they would have recommended catheter angiography and laparotomy for diagnosis of bowel ischemia. And it wasn't into the early noughties, the 2003, Kirkpatrick et al. Published a seminal paper which really set the stone into putting CT in the mainstream use of diagnosing bowel ischemia. And in that study, they used 2 phases, an arterial and portal venous phase. And with that protocol, they identified all 26 cases. It's not a big number, but this was a prospective study. 26 cases all detected, by these radiologists with a sensitivity of 100% and specificity of 89%. So they misdiagnosed 4 cases of bowel ischemia when they didn't have bowel ischemia, which is understandable, I suppose. But subsequently, studies have also been, shown similar SNS. I think in 2010, Mankey et al. Published this, just Mankey actually, published a systematic review and meta-analysis. And by applying the CADAS score, they identified basically 6 studies which met the criteria and which included at least 10 disease cases and at least 10 control cases. So quite good quality studies, but the numbers were small. And they found pooled sensitivities of 93% and a pooled specificity of 96%. So is this reflective of what we see clinically in your practice? I'm not so sure, because these studies, apart from this one here, Weissner et al., where you can see they had lots of control cases, because ischemic bowel is rare. I think these is a bit artificial. A lot of these ones, like for example, Kirkpatrick, the scans were read by 2 radiologists, often in consensus. So it doesn't truly reflect clinical practice, but CT does have the potential to yield quite good results. So how do we get better CT images? I would certainly recommend a triple phase CT, so get a non-contrast, which will allow us to detect any calcified thrombi in the arterial system. Most importantly, it serves as a baseline to ascertain for bowel enhancement on the later post-contrast phases. And on this non-contrast CT, we can also see what we call bright bowel, so hyperdense bowel before contrast. So what we mean by that is bowel that is bright on the pre-contrast, reflecting submucosal or intramural hemorrhage, indicating bowel ischemia. On the arterial phase, it's good for evaluating arterial stenosis, any thrombus or emboli, and occlusion. Also, we can also assess for bowel enhancement. But many of you will know that the portal venous phase is our workhorse of abdominal imaging. On it, we can assess the other organs for any other abdominal pathologies, the liver, the spleen, the pancreas, and also we're also able to gauge bowel enhancement. Again, a second shot at this after the arterial phase. Most importantly, if you're querying bowel ischemia in your subset of patients, please do not give them any positive oral contrast before the CT scans, because what is